This is a case of a type 1 non-displaced intra-substance ACL injury, which would be analogous to either an ACL sprain or a partial thickness tear of the ACL. And this case is one of a partial thickness tear of the ACL. As you can see while I'm scrolling on the coronal images, that there is high signal within the upper to mid segment of the ACL, and on the sagittal images there is quite significant swelling of the ACL with high signal noted within the ACL itself. And you get the sense that there is a partial thickness tear or intrasubstance tear of the ACL without frank rupture of the ACL. There is, in this case, no other significant concomitant injuries noted. So this was what we would classify as a type 1 non-displaced intrasubstance tear. And this is a case of a type 1 non-displaced ACL rupture. So in this case, on the sagittal images, you can see that there is a clear upper segment ACL rupture. And as you scroll on the sagittal images, it is truly non-displaced because there is no ACL tissue displaced external to the notch, which also can be confirmed on the coronal sequences as you scroll from anterior to posterior, with all of the ACL tissue still sitting nicely within the intercondylar notch. The reason why this is a type 1 injury is that you can see the femoral footprint of the ACL nicely attached, and that there is no tear involving the femoral footprint of the ACL. This can also be confirmed on the sagittal images that shows the femoral attachment, as well as on the axial images where you can see the femoral footprint of the ACL still attached. Now we're going to go through a case of a type 1 displaced ACL rupture. So in this case, as I scroll through the coronal and sagittal images, you'll notice that there is a true ruptured segment in the upper segment of the ACL with a cleft in the ACL. As you scroll on the sagittal images, you see this low signal intensity focus, which on the coronal images is also clearly visible. And this is piece of the tibial-sided fibers of the ACL that are displaced external to the intercondylar notch and now sitting beneath the lateral femoral condyle and superior to the lateral meniscus anterior root attachment. This is pretty much the most common of all displaced areas to find displaced ACL tissue. This is not a large piece of displacement. Often they can be significantly larger than this. The reason we know that this is a type 1 injury, again, is that you can see the femoral footprint of the ACL nicely attached, and that there's no tear extending into the femoral footprint. You can confirm this on the axial sequences, and in this case we even have the coronal oblique sequences. The oblique sequences nicely show the femoral footprint of the ACL being attached, and on the axial images as well. Here's the femoral attachment of the ACL, which is nicely intact. So the next case we're going to do is that of a type 2 non-displaced ACL injury. So the only difference in these cases is that there is some extension of the tear to the femoral footprint of the ACL. I find that most easiest to determine on the axial images or the oblique images. We don't have the oblique images in this case, so I'm going to show it to you on the axial images. And it's most likely that most of the times when you're interpreting the scan, you may or may not have the oblique images to look at in any case. So in this case, you can see that there is a ruptured ACL with a detensioned ACL, a rupture zone that's clearly visible here. And as you scroll on the sagittal images, there is no displaced ACL tissue external to the intercondylar notch. And you can confirm that again whilst you scroll on the coronal images, that there is no tissue external to the intercondylar notch, deeming this to be a non-displaced injury. Whilst the tear is in the upper segment of the ACL, as you scroll the coronal images, you get a sense that there is some high signal in the ACL extending up towards its femoral footprint. And similarly, you get that sense on the sagittal images too. So the axials show that this is the site of the ACL rupture. And as you scroll more proximally, you can see that fluid signal intensity cleft, and this cleft extends right up to the femoral footprint of the ACL, deeming this to be a type 2 non-displaced ACL injury. Next, we're going to go through a case of a type 2 displaced ACL rupture. So as I'm scrolling through these images, you can see that there is a clear ruptured proximal segment of the ACL. And as you scroll on the sagittal images, there is a displaced fragment from the tibial sided fibers of the ACL sitting beneath the lateral femoral condyle and superior to the anterior root attachment of the ACL. This can be confirmed again on the coronal images. As you can see here on these images, there is tissue laterally displaced from the tibial side of the ACL. The reason we suspect this to be a type 2 injury is that whilst the tear on these images is seen in the proximal segment, there is a cleft of high signal or fluid signal intensity signal extending right up to the femoral footprint of the ACL. And as you scroll on the axial images, this is the tear of the ACL through that area. And as you come proximally, you can see that fluid signal intensity cleft attaching onto the femoral footprint of the ACL, deeming this to be a type 2 displaced ACL tear. This is a case of a type 3 non-displaced ACL rupture. On this case, on these sagittal images, you can see that there is a proximal segment ACL tear with a bare femoral footprint of the ACL, with the ACL tissue largely retracted down from the native femoral footprint, consequent of an avulsion at the femoral footprint of the ACL. There is no ACL tissue seen attaching to the femoral attachment with the redundant detensioned ACL tissue noted within the notch, and there is no displaced ACL tissue, in this case external to the notch, medially or laterally, deeming this to be a type 3 non-displaced ACL rupture. So this is a case of a type 3 non-displaced distal ACL rupture where there is bony avulsion at the tibial footprint of the ACL. So here on the sagittal images, we can see that the ACL remains taut, but there is a bony avulsion at the tibial footprint of the ACL. And this can be confirmed on all three sequences with this low signal intensity bony structure. In this case, we also did a CT to prove the bony avulsion, and here it is on this CT. You can see a linear bony flake that's been avulsed off the tibial end of the ACL, confirming this to be a type 3 distal bony avulsion at the tibial footprint of the ACL. This is a case of a type 3 distal ACL rupture without a bony avulsion, but just a soft tissue avulsion of the ACL from the tibial footprint of the ACL. So here we can see the ACL coming into an area of high signal and a fluid signal intensity cleft separating this ACL from its tibial footprint, compatible with a type 3 distal ACL rupture. Okay, this is a case of a type 3 distal tibial avulsion fracture at the tibial footprint of the ACL with clearly visible bony fragments on both the CT and the MRI in a skeletally immature patients with open growth plates. So on the MRI we can see the low signal intensity bony fragments avulsed away from the native tibial footprint of the ACL, which can be confirmed on both the coronal and sagittal CT imaging done at the same time, showing the avulsed bony fragments from the tibial footprint of the ACL. This, in the classification, would be classified as a type 3 non-displaced distal tibial bony avulsion injury. This is a case of a type 3 ACL non-displaced injury in a pediatric patient involving the proximal femoral footprint of the ACL. As I'm scrolling through these images on the coronals, you can see a clear cleft at the femoral attachment of the ACL, separating the ACL from its femoral attachment. The ACL on the coronal images still remains within the intercondylar notch, deeming this a non-displaced injury. This can also be confirmed on the axial images where you see a clear fluid signal intensity cleft separating the ACL tissue from the femoral footprint of the ACL. And again, the sagittal shows the edema within the proximal ACL, whilst the coronal and the axials better define the lack of attachment to the femoral footprint of the ACL. This patient also ended up having a CT, and on the CT it confirms that there is no bony avulsion at that femoral attachment of the ACL, deeming this a soft tissue avulsion injury.